In every drop of blood, there's a story. Dr. Thomas Slavin shows us how to understand it for life-saving decisions. Today on DocStars.
Welcome to DocPod's DocStars.
Hello, everyone. I'm JJ, and thank you for joining us on DocStars on the DocPod channel. Today, we're joined by Dr. Thomas Slavin, physician, scientist, and molecular oncology leader at Quest Diagnostics. Dr. Slavin reveals how cutting-edge tools such as MRD, minimal residual disease testing, and ctDNA analytics are transforming cancer care from early detection to treatment monitoring with precision, speed, and real clinical impact, which is amazing. Dr. Slavin, welcome to DocStars.
Yeah, thanks. Happy to be here. Thank you for the invitation.
Yeah, no, thank you for taking the time. We know how busy you are. So let's talk about, first of all, background and mission, because for me, I'm always wanting to understand the why and everything, but I know you're triple board certified in clinical genetics, molecular diagnostics, and pediatrics. What inspired your journey, particularly toward molecular oncology and also precision diagnostics?
Yeah, no, thank you. I always really had the mission of driving, high complexity molecular diagnostics into routine clinical care, and I think it just came out of the time we're all we all come from a product of our environment, and genetics was really emerging in the 90s, and it was something I became very interested in school. Wanted to, potentially even do a PhD in genetics, learned that there was a field of medicine that took care of patients with genetic issues. And, I easily gravitated towards that. And I just always loved the research and education, because it was really this very attractive, high-paced, growing field. Every day there was like something new and exciting, like Dolly the sheep and things. If you remember, cloning and yeah, there was just so much going on. So for me, it was just something I just was always excited about intellectually. And then once I realized, you can take care of patients with genetic conditions, and then even on top of that, it was that, you can take genetics mainstream. And, once you start realizing that, we all have genetic mutations and issues and different things. Sometimes we're lucky enough they're, recessive conditions and things that aren't going to affect us. Sometimes people have conditions that will affect them. But we all are plagued by this, and it sometimes when you're having children, like even if you don't have a change yourself that's affecting you, you could pass something along. And if your partner has the same, you could have a child with some condition that would need treatment and management. So it really affects all of us. And I saw very early on that this was going to go very rapidly towards mainstream, especially in the cardiovascular, heart disease space, cancer space. So that was always my main interest. Did a postdoc in molecular genetics. So that's how I ended up with a board in molecular diagnostics as well. And then, clinical genetics and, pediatrics really just came out of, at the time, I knew I wanted to go into genetics, and that was a 5-year, I was looking for 5-year programs. And genetics really birthed out of pediatrics in a sense, because if you think about it, taking care of children with like trisomy 21, sometimes known as, people know it as Down syndrome, those types of conditions really came out of pediatrics first and foremost.
That's really interesting, because when I follow people like you, and you have a really interesting background, when I started kind of deep diving, what you've been doing and kind of understanding your journey. And I always think about, for me and even my own life and family and friends, there are personal stories along the way that can really get us even more focused on what we find is very interesting. So what I want to know is, were there personal or clinical moments that shaped your belief that molecular oncology would transform patient care in our lifetime?
I think once I started seeing that, there was, particularly conditions like, BRCA1 and 2, like hereditary cancer, genetics, that, a lot of individuals would carry variants in these genes that, you could go and you could actually do risk prevention in, individuals, take a woman with a BRCA1 mutation. There's things you can do. You could, the rate for ovarian cancer is very high. You can do prophylactic removal of the ovaries. The rate for breast cancer is very high. Well, if you remove the ovaries and reduce, estrogen stimulation, that reduces your risk for breast cancer. Or you can layer on top an anti-estrogen pathway medication, or you can do prophylactic removal of the breast if needed. So there were things you could actually do to keep people safe. And what was always amazing to me is you could, if you knew what that person was at risk for, by the time you do some of these risk prevention measures, you could take somebody back to normal population risk for cancer, or sometimes even less, which is incredible.
Yeah, it's amazing. And what I love about this is because you're with Quest Diagnostics and they're such a big player in the space. And I think all of us on this side as patients, I know me personally, I really wanted to know any predispositions I might have genetically. So I want to understand my biomarkers as much as possible outside of, let's say, the routine labs that you get. And so I love that we're able to do that. And so I want to know a little bit more in terms of, after you were over with Myriad Genetics and you were providing leadership there and Halo Precision Diagnostics, what drove your transition to Quest and also the molecular oncology portfolio that maybe they possess?
Yeah. Quest is one of the largest labs in the world. And if my preamble, as we were talking about, is, driving access to everyone. And I saw and still absolutely see Quest and know now that being at Quest, my 1 year anniversary was actually just 2 days ago, this is really the way to do it. A lot of genomic testing is becoming very commoditized in the sense that there's not a huge difference between one reputable lab finding a mutation and a nod in somebody's tumor or in their blood. But then there's some really unique things that, I'll talk a little bit about the emerging field of this minimal residual disease testing a little bit. But even on top of that, it's all well and good. You could have a great test, but if you don't have market access, you don't have logistics, it's hard to bring these types of tests to the masses. So what better place than, Quest that has 2,800 plus, patient service centers, pretty much almost one on every corner. A lot of people, obviously that are listening to this have had their blood drawn at Quest centers. There's, mobile phlebotomy with our Exam One services, all the payer contracts and market access that we work with insurance companies and health plans and health systems. So it's really, to me, it's really just amazing to have this large of an access ability. And then you marry on this merging genomics profile that we've been developing, and I'm fortunate to be part of that, really this A to Z suite of solutions and start packaging it up. It's very exciting.
I love it because I find it really interesting. I remember I went recently for some basic lab tests with my primary care provider. And I asked them, I said, oh, well, do you guys process that here? They're like, oh, no, we send it over to Quest. So I think a lot of us don't even realize how many of our care centers around the U.S. use Quest on the back end, right?
Mm-hmm. Yeah. And just the scalability, it's just, it's incredible. I mean, we run around 500,000 to 1 million tests a day. So, I mean, It's just very different than, a small boutique type genomics lab, on the scale. And, it's just a good example is, we launched this minimal residual disease test and, I'm just watching the turnaround times go down like literally every week because our lab is so sophisticated and we're just plugging it into something that's so operationally savvy. We just have such great experience on the team that, it's really just impressive to see.
Yeah, you have a huge data set, right? You have huge quick turnaround time, and that really helps with what you're doing, I would imagine.
Mm-hmm. Absolutely.
Yeah. So I'm curious though, when you are working in a smaller role, let's say, that's evolved from innovating in a smaller space, right? A very agile environment. I know even in business myself, it's one thing when you are in that smaller agile environment and then you move on to, as you just discussed, onto a much larger global diagnostic leader, you can leverage the scale. Maybe talk to me about that. How has that role changed for you?
Yeah, it's been interesting. In a weird way, I've only, I'm really an academic at heart. So, I always really came out of clinical medicine, academics, research, seeing patients. I mean, that's where I lived my, most of my life. And then, around 5 years ago, transitioned into the role at Myriad Genetics and the leadership, and ultimately was CMO there. And yeah, a smaller company when compared to Quest. But you see a lot of the same issues, that are very common just to any industry. Things like IT infrastructure when you do acquisitions, and getting everything set so you can have systems flow easily from one spot to the other. So there's a lot of commonality. I feel like I'm in a great spot in the sense that I'm also medical director for Haystack. So Haystack was an acquisition, which was a smaller company that Quest purchased around 2 years ago, and that has the minimal residual disease assay. So as medical director of that, I have a foot a little bit in both sides at Quest, because Haystack is a little bit more nimble, sometimes because it's a smaller team, things can flow quicker, everyone knows each other. But it is, and ultimately is very rapidly becoming very integrated into this bigger Quest infrastructure, which in a sense, I haven't noticed a lot of, major challenges there, because even though Quest is such a big company, it's segregated well into divisions, and oncology is somewhat of a very close family, I would say. So I haven't really noticed anything. I've been pretty happy here. I feel like we're actually moving very rapidly, and sometimes I'm truthfully surprised how quickly we can move, like bringing up new lab tests or EMR integrations and things, just because we already have so many resources at our fingertips, and we already have so many back-end established connections and things throughout health system networks. It's been incredible.
Yeah, and that's amazing. Let's discuss actually the kind of expanding access, right? Using the Quest and also understanding Haystack MRD. So at Quest Diagnostics, you're building out this Haystack MRD platform. So we can kind of frame this, and we all understand, what is MRD testing and how is it changing the cancer care continuum, if you will?
Yeah, minimal residual disease testing, which is what you'll hear a lot of folks call MRD. Just for short, is really amazing. I mean, I haven't seen many things catch on this quickly, in the field of high complexity molecular testing. So, because if you think about it, even hereditary cancer testing, I mean, here we are, BRCA1 and 2 were founded in the early to mid 90s. They were commercialized, we're 30 years out now, and they're still having trouble with uptake. People are still not getting screened appropriately. Physicians, due to lack of education or perceived barriers and things, still aren't routinely ordering this type of testing. It's well established in the guidelines. So, that's kind of one end of the spectrum. I would put minimal residual disease on the complete other side of the spectrum, which is, when you look at data, depending on what you're looking at, 60, 80% of oncologists have already ordered one of these tests. I mean, it's only been out a handful of years. It's, rapidly emerging into guidelines. And I really think because it's real-time tumor, it really fills a niche in the sense that it's real-time tumor testing. So what I mean by that is, to date, when it comes to, a patient, unfortunately getting cancer, trying to manage that cancer, we have been limited in a sense. We have imaging, and you think how imaging has gone. I mean, we had X-rays, radiographs, that is, they're even still there. Lots transitioned obviously over to digital. We have advanced imaging, ways to look deeper and deeper and smaller at tumors. Well, that's now here for the molecular side of blood work. We haven't really had great biomarkers until recently, in the sense that, a lot of your audience will be familiar with PSA, prostate-specific antigen, very common blood test, CA-125, very common test for looking for signs of ovarian cancer. CEA, is used in some GI malignancies and things. But these are protein biomarkers, and protein biomarkers have, they're kind of fraught with some challenges, and some of that is just half-life. They have 7 to 10 day half-life, so they don't move very fast. If there's somebody's responding to something, or after the surgery, it just takes a while to see changes. That's not circulating tumor DNA. Circulating tumor DNA is DNA that's coming out of tumor cells when they're shed. So, if you don't have any tumor cells in your body, you shouldn't have circulating tumor DNA. So if you had surgery and the tumor was completely removed, that should be the end of your circulating tumor DNA. And because it has such a short half-life, you can follow it very closely. So over a few days, even, you can see a really rapid change in the circulating tumor DNA levels. Likewise, you could put somebody on a therapy that still has cancer in their body. You could see the circulating tumor DNA levels plummet. Or if, it's not working, you could see that they're staying up. So, I mean, it's just this new ability to really, look at patients very closely and use blood now in a very clear manner to help manage them. And it is an emerging field. So, we definitely need guidelines. There's a lot of studies ongoing. I think there's some better use cases already emerging clinically, but I'm seeing people use it across the board. It's really been impressive to see how fast clinicians have adopted it.
It's amazing. Actually, I was diagnosed with prostate cancer in October of last year.
Yeah.
And I had been, I've been checking my PSA all the time because my grandfather had prostate cancer. It didn't kill him, but he did have it. So I started checking probably around 8 to 10 years younger than I even should have. I was testing in my early 40s, knowing that my grandfather had it. And I just paid on my own to make sure I got the PSA numbers checked, but I was moving around a lot. And so when doctors would see that PSA, they were looking at it and saying, oh, it's under 4, you're fine.
Yeah.
But I think it's also about the correlation, right? And that PSA was going from 1 to 1.8 to 3.6. So it was moving rapidly. And ultimately, we were able to get it under control. And I had my prostate removed and all the cancer. I'm cancer-free now, which is amazing. And so it is interesting to see how this blood work, because I think a lot of us, when we think about what you're doing, we think about the blood work like the PSA. But I think what I'm hearing is, as we advance, we'll be able to look at our blood work and detect many more cancers in the future, right?
Yeah, I think there's kind of two fields right now. There's the pre-cancer and there's the post-cancer. So, the pre-cancer field has been emerging very rapidly. So that's just the patient screens, and there's a lot of tests. Like, for instance, Quest has a relationship with a company called Grail, and Grail has a test called Gallery. This is the one probably a lot of folks are familiar with on this call. It screens for a lot of different cancers, and it's a great test. There's tests that are, and obviously they're looking at different versions, but there's a lot of tests in that category. And sometimes you can marry that to like PSA and protein biomarkers, like Quest is doing has been publicly announced a relationship with MD Anderson, looking at some ways that we can put a lot of protein biomarkers together for a very inexpensive test, for instance, to do some screening. So there's a lot of excitement going on there. I was also chief medical advisor of a company called Oncology, so I know a lot about this space in general. And they were an early cancer detection company. But then once you have cancer, now in a sense, the difference is you already know what the cancer is. I mean, the challenge with the pre-cancer tester, you haven't been diagnosed with cancer yet. You don't, you're having to make more of a generic test, I would say, for lack of better terms, to look for, signs of cancer, fingerprints of cancer in the blood. Once you've been diagnosed with cancer, you can still use tests like that for sure. But in some instances, it's nice to have the luxury of knowing what the cancer is. So, a test like, Haystack, we actually then take the cancer itself, take the actual tumor tissue, grind it up, pick mutations, make sure those are pure tumor signal mutations in the sense that we look at mom and dad genetics. We look at background kind of clonal blood errors that you could potentially have. We take all that out. So you end up with a very clean, personalized panel specific to your cancer. Like there is no one else in the world, with that exact panel, which is incredible. So now you have this is the true realization of personalized medicine. So you have a personalized panel, and now you can follow a patient with. And yeah, in some circumstances, like, as you were describing, now that you've had your prostate removed, they're going to be following you with PSA levels. And if something's seen, that's called biochemical recurrence in the field of urology. And then that means that there's probably some, prostate tumor tissue left. But let's say, for instance, you had, what's called prostate focal therapy. So let's say you didn't have your complete prostate removed. You just had a portion of your prostate burned out or frozen or something. There's all kinds of different ways to do prostate focal therapy. you wouldn't necessarily have that same exact luxury of looking at just PSA recurrence at that point, because you would still have prostate gland, and it's still going to be putting out prostate specific antigen. So it might be more interesting to have a circulating tumor DNA test, for instance, in that point, because now you're looking specifically for that cancer if it's reemerging. And these tests are different in the sense that if you have a personalized cancer signal and those tests are positive, that means there's cancer somewhere in your body. It's not really like I know we call them prognostic at this point, but they're really almost diagnostic, because if you see that positive symbol, a signal floating around in the blood from a personalized panel, there's cancer there, or it just has to be found at that point. And then it becomes these kind of difficult questions on how to treat it, but that's why we need all the studies and research and things.
Yeah, 100%. And at the top of the show, we talked about Quest's infrastructure, right? And the reach that they have. I mean, it's such a big company, and that enables more widespread adoption, right, of next-gen molecular oncology tools. Maybe speak to that a little bit so we can all understand that side of it.
Yeah, I think it's, having everything in one place, that's a big one. Leveraging a lot of our infrastructure and health system relationships, leveraging a lot of our payer access and work-related, access programs. Those are really unique, to Quest. And, think about it, like the test I'm talking about, having, it requires blood. Well, you can get blood drawn in your doctor's office. But what if your doctor, wants to just see if you're, here you are at your 3-month checkup, and maybe that they want to look at it through, see you through telemedicine or something, and just have the blood drawn somewhere else. Well, with all the reach that Quest has, that could be done through mobile phlebotomy. Somebody could come to your home and draw it. It could be done at a patient service center, which are all over the place. So there's just a lot of access there. And again, I think it's really think about it as the whole portfolio, having that and I was just on, for instance, with a health system, and, there was a discussion, we send this test here, we send this test here, and this tumor test we send here. But then when we want to look at tumor in the blood, we send it to this lab. And, it's amazing how fragmented all these systems can get. So I think there's a real utility of having it all in one place. And again, a lot of this testing is becoming more commoditized. There was, when you look back 20 years ago, there was a need to have specialized labs, doing these kind of work. There also wasn't a lot of expertise out there in the workforce. But now there's a lot of mature expertise in the workforce that, fortunately, I'm able to leverage in my daily job now. We have some fantastic people, and there's no reason that a lab, even as large as Quest, can't be doing some of this testing. And, because of that, we built an oncology center of excellence in Dallas, Texas. It's at our Louisville site. And it's just amazing to see everything coming together, and what it's going to mean for patients and health systems.
You know what I love that you mentioned right there was about it's so fragmented. And I seriously, I feel like it's a little bit like having a mom and pop shop, right? We have thousands of these little mom and pop shops all across the US, let's say, collecting all this blood and doing amazing things with it. But if it's hard to correlate those from all those places if they're all different. And so I love that when you get scale, right, with what you have at Quest, it just makes it so much easier to have all of that under one umbrella where you can really get to that and see those correlations, right?
Yeah, absolutely. And some things are, very precious. So, if you have a cancer taken out of your body, most of the time, fortunately, it's a small cancer, and there's only so much tumor tissue there. So it's nice to be able to send it to a lab that not only could, grind the tumor tissue up and look for and make this type of panel that I'm talking about, like a personalized panel that they can follow you over time for the rest of your life with. But you could also take that same DNA right out of that same tissue and do a treatment selection panel. So you could see immediately what, treatments might be good for you from a chemotherapeutic standpoint. So your doctor can help manage you. So it's just really nice to be able to, there's just, there's a lot of, ability to scale and do, and leverage some of these shared tests.
Yeah, and obviously, even just because of the scale and the sheer size of Quest, you guys cover so much of the U.S., but if we were thinking about systems in place to make sure this technology reaches people in smaller towns, if I'm listening to this podcast and I'm in a town of 2,000, I mean, does Quest have that massive reach, or what does that look like to having access to major cancer centers or getting some information
No,
to
it's
you
incredible.
guys?
Yeah, it's incredible. I mean, yesterday, again, example, a real life example. We were talking about someone in Kodiak, Alaska, and they wanted to send a sample. And it's like, well, we don't have, like, oh, how can we do X, Y, and Z? And how can we get, everything to them and get it ordered? And, if the clinician wants to keep ordering, how for their patient, how do we set things up? Well, it's great because we have pathology centers through Quest. We have the largest pathology networks with Ameripath and Phenopath and others. And we have sites in Alaska, and they're already taking it in, which means we already have a lab to lab, connection, and we already have electronic connections and can take all that data in very easily and set up ordering pathways. So it's amazing to see that reach beyond, all the large cities that, a lot of the more boutique labs focus on. There's a huge need in the community to get, still this type of testing is very, it's lacking significant uptake in the community. Even things that have had guidelines. I mentioned, hereditary cancer testing before with BRCA1 and 2, but even tumor testing and looking for mutations to help guide therapies, that's still lacking. In certain places in the country, and still just talking about the U.S. But to bring all of this access, it's really incredible. It's why I'm so excited to be here. Yeah.
Yeah, I think it's really fantastic. At the top of the show, I heard you mention circulating tumor DNA, right? ctDNA. So maybe describe what that is so we all understand, and how detecting that actually can alter, treatment decisions, for example.
Yeah, for sure. So circulating tumor DNA is this, I had mentioned minimal residual disease, or the MRD testing. So this is this new area of a really rapid uptake of, clinicians getting excited about this type of test because it's a real-time tumor test. So tumors, when they're growing or when they die and changing, they release all kinds of things. One of the things they release is DNA. So circulating tumor DNA. All of our cells all the time are releasing DNA into so that's cell-free DNA. It's just DNA floating around from everything else. But circulating tumor DNA is something very specific. It's, coming specifically from that tumor. So if you know what mutations are in the tumor, you can look for those mutations in your blood at very low levels. I mean, again, there's other ways you can do this, but, when you look across the board at, what's been commercialized and is available right now. And a lot of this DNA is very stable in the bloodstream, and it has some unique features where, usually the DNA fragments that are floating around are a little shorter than sometimes the blood fragments that are coming from your other cells. So there's some opportune ability. And then just the field of sequencing. I mean, I think most of your listeners would know that, sequencing costs are coming down every single year. You kind of hear that here and there, even if you're not in the science field. There's just a really amazing ability to look very deeply now for DNA floating around in the blood from the tumor itself.
Yeah, and I love the whole concept that we can go deeper into the blood, right, to try to find, and discover what's going on there. So if I'm listening to this, or if I'm watching this and I'm thinking to myself, I've had imaging tests done, et cetera, how do I weigh, or how do you weigh that ctDNA finding against imaging or even pathology if they don't align? What does that look like?
Yeah, I think these are all tools in your tool belt when you're a clinician. So, that's the way I see it right now. Will, 50 or 100 years from now, we be doing circulating tumor DNA in some capacity over imaging? Maybe. It is, when you look at certain studies, you'll see about a 6 to 18 month lead time, on finding something in the tumor floating around, in the blood floating around over, sometimes when you can see it on imaging. And some of that's just the nature of imaging, because, even advanced imaging like MRIs and PET scans and things, usually like 1 millimeter, you got to have some clump of tumor, at least enough that it can show up. And, circulating tumor DNA through these, that can be detected through these really sensitive methods, it can be seen before it's even that big. So, that's the conundrum. So right now, that's the major clinical conundrum right now. A patient had cancer, they're doing these type of new fantastic tests, they're seeing a positive signal with these new fantastic tests. So there's highly likely that person's tumor is not completely gone. There seems to be still circulating tumor DNA, but nothing is showing up on imaging right now. That's very difficult. As a clinician, it's very difficult to know what to do. What I'm seeing in the field is, providers are at least following those patients much closer. They're much more guarded when they talk to the patient about them being potentially cancer-free. So, kind of more of a guarded prognosis, we would say, in the medical field. So there's a lot of studies going on right now looking at, can we add a medication at that point, like a chemotherapy, even before something's seen on imaging, and have longer survival for that patient, or maybe they never have a radiographic or imaging recurrence at that point, and they're completely treated and their circulating tumor DNA goes back to zero. So those kind of studies are going on, or should, if they're already on one chemotherapy, can you add another one at that point? So there's a lot of, movement in the field to try to answer those questions. There's also some very clear-cut, in my mind, use cases coming up right now. So, we've been fortunate to be part of some of that research. There's one randomized control study that's kind of the gold of research when you're talking about studies. Prospective randomized control trials is about as good as it gets. And that was looking at that study is called Dynamic. That was done with an earlier iteration of the Haystack assay. But essentially, it took patients with stage 2 colon cancer, which is a very tricky cancer to figure out, should I treat this patient with chemotherapy? Most don't benefit from chemotherapy. Chemotherapy, as everyone knows, has its own, adverse risks. And, you can have all kinds of issues just from chemotherapy. It's also expensive for health systems and insurances and just our country in general. So, could you say, after surgery around 4 weeks, could you test that person? If they have circulating tumor DNA, could that'd be a good person to give chemotherapy to. If they don't have circulating tumor DNA floating around, that's probably a good person to not give chemotherapy to. And that was how the study was set up. And the whole point of it was to show that you could reduce chemotherapy use, and the results showed by half, with the same exact patient outcomes. And actually the 5-year data was just published in Nature Medicine. So really just fantastic work by the investigators. So that's a pretty good use. Also recently there was a paper by Memorial Sloan Kettering Group that looked at, and this was just incredible, and it made a lot of national press and news. Just taking a stand back as a clinician, I mean, it's amazing. So non-operative management of patients, meaning that you have patients with cancer, can you give them a medication and never take them to surgery, never take the tumor out of their body? Incredible, just as
amazing.
Amazing. And in certain cancers, you can. So, around 2 years ago or so, this same group had a paper in the New England Journal of Medicine, and it looked at rectal cancer patients. Rectal cancer surgery is a major surgery that could be life altering forever for that person. They might need, all kinds of different ways to make sure they have control of their bowel at that point.
Yeah.
These patients were given, and these were patients with what's called deficient mismatch repair, which is like a specific tumor signature that's very receptive to this new class of chemotherapy called immuno-oncology chemotherapies. So they were given immuno-oncology chemotherapy, what's called sometimes IO therapy, and for 6 months. And, now really they all had a complete clinical response. And the 5-year data was just shown in that rectal cancer cohort, really incredible. And you can just see their circulating tumor DNA levels just drop. And it just correlated so nicely with what's going on and that these people weren't going to need surgery. And now they've even extended that in a most recent paper that was just published in the New England Journal of Medicine this year, beyond rectal cancer. They looked at other cancers that have deficient mismatch repair, but really some high, morbidity cancers, like, things that you would need your bladder removed for, your stomach removed for. So, the fact that you could give somebody an immuno-oncology agent, 6 months, most people handled it very well without adverse reactions or anything. and you don't ever have to take that patient to surgery. It's life altering. So, and that's a nice one for monitoring patients with circulating tumor DNA, because you can see if it's still lingering and hanging out, and our assay was used in the study. If it's still hanging out, yeah, that person is not gonna, they're not responding. You have to do something else, take them to surgery or add another, treatment at that point.
Yeah, and as I'm listening to you, I'm actually thinking, I'm going to ask a question off topic, because as I'm listening, I find this very interesting. Why don't people, let's say the average person like myself, why don't we hear more about, ctDNA or MRD? Is it because it's still fairly new, or maybe what's that about?
Yeah, I think because it's pretty new. It's only been
Yeah.
commercialized for a handful of years. And insurance coverage is still emerging. It's just a pretty new field. I mean, there's only a few, morsels of guidelines out there from national guideline committees. There's a lot of studies going on right now, but I can tell you from, traveling around the country and, talking with a lot of oncologists and clinicians, it is being used right now. So no question, a lot of patients are getting it done. Some patients are actually even advocating for it. For their clinicians. And yeah, it is, unfortunately without firm guidelines, and, I gave some pretty clear use cases there. But outside of that, it's a little bit like the Wild West, but it is interesting to see how some providers are using it. I mean, we just had a publication where we talked about, it was in Case Reports in Oncology, and we talked about a scenario where it was a patient with breast cancer, and it was a very high risk breast cancer. A lot of the lymph nodes were positive. I mean, the lymph nodes that kind of were feeding from the cancer itself. So positive for small bits of cancer. So that's always pretty concerning that the cancer might have spread throughout the body. And then this patient had what's called a like an estrogen PET scan. It's a special type of PET scan, FES PET. And in that scan, there looked like there could have been, something lighting up. It was a little bit, where, the molecular tumor board and the clinician, who was the co-author with me on the paper, I think people were a little bit, confused on what it was, highly suspicious that it was cancer. But then we did the liquid biopsy blood test with the circulating tumor DNA, and it came back positive. Well, there you go. I mean, at that point, you have something that looks really concerning on imaging. You have a test that came back positive that was a personalized cancer test for that patient, meaning it's highly, highly, highly likely that there's cancer still in that patient's body. So it just, again, that's kind of that getting back to that whole tool. It's like another tool in the tool belt that, in breast cancer, yeah, there's, CA15-3 and some other biomarkers that are sometimes used. But again, they just haven't really, they're not as sensitive and specific sometimes, like when you look at the data, as these new types of tests that are emerging.
Yeah, 100%. And I love the way you kind of talk about the tool belt, because, years ago, go back as far as you want, you might have had one tool, and then we added another tool, and then another tool. And it's more indicators, right? Which is only going to help. This may be a stupid question, but could someone go to Quest Diagnostics, obviously see their primary care provider first, and mention an MRD test, or a ctDNA test? Are they going to actually write them something to say, hey, you can go to Quest and get this done? How's that evolving right now?
Yeah, I mean, we've just commercialized this test, so we're still getting the word out. But absolutely, we still, we still need a physician signature. So someone has to order the test themselves. But yeah, once it's ordered, and now it's orderable in the Quest system, which is, a lot of clinicians have access to across the nation. So now, once it's ordered, that's pretty straightforward at that point. So
that's amazing.
Harder to sometimes figure out what to do with it if you're the physician. Again, if the result comes back positive, if it's not one of these clear-cut use cases. So, I would say from a patient standpoint, don't be surprised if, you bring this up with your doctor and they say, well, like, I don't know how I would exactly use this, because it is emerging again. There's a couple clear-cut use cases. I think some better use cases kind of under that, where, you're trying to figure out if something's there or not, that you might be seeing. And again, you're using it as another tool, but then sometimes it's just a little bit murkier for the clinician to know exactly how to use it. But it is, I would say, clinicians are starting to get more and more comfortable with it. And as I, brought up in the past on this podcast, that, at this point, it's more often now that an oncologist has some experience with this type of testing than they don't.
Yeah. Yeah, and obviously the more we can talk about it, the greater the narrative, right? The more doctors will start to lean into it, obviously. And
Hmm.
primary care providers, they can't be expected to know everything, but it is
Right.
great to see that they can start to lean into this as, it starts to get released. And what I think is interesting is that I always think of doctors, and the ability to really help people. And when I went through my own situation with a couple of different doctors, you have to find the right doctor that works for you, that you feel comfortable with. But I'm wondering from your point of view, what does it feel like, for patients when you're doing MRD testing and it shows that they don't need extra chemotherapy, because you're able to do this and therefore they don't have to do that. You mentioned earlier about being proactive and maybe that incredible test you had referenced and not actually having to go to doing some sort of procedure. But I always think
Hmm.
about what if, you can use this MRD testing and then you never even need to go to that chemotherapy. I mean, what does that moment look like for you as a physician? How happy are you? It must be amazing.
Oh yeah, no, it'd be incredible. To be able to tell it, just a reassuring standpoint. I mean, none of these tests are perfect. It's
Yeah.
we'll get better and better tests over time. We can go very deep right now. Very very deep in the blood, looking for signs of tumor. Could tumor not be shedding that day or that morning when you went and had your blood drop potentially, especially at very low levels. So it's never an absolute, but and it's always from a physician standpoint. It's harder to, especially when something's in guidelines already that that patient should be getting a chemotherapy. It's very hard to de-escalate care. It's generally almost easier to do the opposite. Where you have a patient that say you weren't going to give chemotherapy to after their cancer, and now the circulating tumor test or some image came back concerning or something. Yeah, that makes it a little bit more clear. You have kind of that discussion with the patient. Look, it looks like there's something still there. It's a little bit more clear cut. The de-escalation is tricky, and it's going to take a lot of studies. Like the one I brought up on the colon cancer, clinicians are starting to use that now. So for stage 2 colon cancer, it's becoming more common. When we look at the tests that are being sent in, most of them, a good chunk of them are for colorectal cancer. That's kind of our number one, use case coming in the door at Quest since we, commercially launched this new test. And from talking with providers, they are starting to use it that way. So it just takes data. You just have to have some confidence in the test, and it's just going to take some time. But yeah, ultimately, I could absolutely see a world where a lot of tests, you sometimes you don't even get your surgery maybe in the future. Talking about what I was discussing before, you could literally take a chemotherapy agent or immuno-oncology agent. Maybe you're completely cured, and you're just followed at that point with circulating tumor DNA levels. And if if and when they pop up, you're treated at that point.
Yeah. Well, that'd be an amazing point to get to. And I am no doubt that we probably will get there, which is
Hmm.
incredible. So let's
I think
discuss
so.
education.
Yeah.
Yeah. Yeah.
Yeah.
Yeah. Let's discuss education, kind of research, and really the future. Because for me, it's very interesting to hear about all these types of developments. It's very innovative. But how do you see, let's say, provider knowledge gaps changing, with these advances in this type of technology and medicine and stuff?
Hmm. Yeah. It's hard. I mean, it takes a while to get information out. That's the bottom line. And
Yeah.
we're still kind of on the early adopter curve, even though a lot of oncologists at this point and clinicians have started using this type of testing to take care of patients with cancer. But it is going to take a while. And if you remember in the beginning, I was talking about just the tests that have even been out for a while, like with guidelines, like, looking at tumor mutations to pick chemotherapies and things. Those still don't have complete penetration across the country. And especially in community areas, sometimes are a little lower. Education is key. So, if you haven't been to med school in the last couple of years, sometimes this is completely new, new types of tests. All of the companies that, generally are out there commercializing these types of high complexity molecular cancer testing have educational forces behind them. So I do, most of my day is actually educating people. Sometimes it's within Quest, most of the time it's without a Quest. Just talking with clinicians, making sure they understand the technology. So, I think when you're out there, lean on, the workforce that is developing these tests. That's a great source of information. But, again, there's, you have to take some of that and run and do some research on your own. Keeping up with continuing medical education is big. They're trying to, that's a key area where they're sprinkling in newer, molecular diagnostic information and things, just so clinicians are staying up on it, which is fantastic. And then there's more formal education, avenues you can pursue. I still sit on the genomics education course for City of Hope, which is largely around hereditary cancer testing. But that's, global educational platform. And, we've trained well over 1,000 people at this point that have taken the course. So I would say, from a clinician standpoint, unfortunately, got to put some work in to understand the tests. But I am very impressed, when I'm bouncing around the country at how savvy, people are. And I think, some of these tests are pretty intuitive. This is looking for cancer in your blood. That's a pretty intuitive test. I don't think you have to know all the nuances behind it.
100%.
Yeah, this is grinding up cancer and looking for the best treatment selection. This test is going to tell you over here if you have a hereditary cancer risk. And if it is positive, you're going to get a lab report that's going to tell you what the actual risks are and how to manage that patient, based on firm guidelines and things. So there's a lot of resources out there. It just takes the desire to lean into it.
Yeah, 100%. And honestly, look, if I'm a doctor and I've been studying this one thing, which is, we know medicine is fluid, as we've talked about today, and I've been studying this one thing, and I haven't really got caught up on the latest within this area. Sometimes there's pushback there. And so the more intuitive you can make it, right, for these physicians, then I think the more accepting, hopefully, it will be for them. That would be amazing.
Yeah, absolutely.
Which I love that aspect of it. So do you think there's like a major misconception about molecular oncology that you find yourself, when connecting with all these clinicians, or how does that look?
Yeah, it's interesting. I'm in a strange way, and again, my lens has been largely high complexity cancer diagnostics my entire life. And there's, something called genetic exceptionalism. And that's more applied to the hereditary cancer side of testing. And there's this concept of, you really do need to have a lot of expertise to do this type of hereditary cancer testing. And that's been challenged over the last 10 or 20 years. These are in guidelines. There are firm guidelines saying you should screen patients coming into your office to see if they're at risk for having hereditary cancer variants, because that could be very meaningful for them. It could be very, very meaningful to their family members. Even if somebody gets diagnosed with cancer, that might not be their only cancer. They might be at a huge risk for a second cancer, even if you cure their first cancer. Or maybe there's some, the way the hereditary cancer mutation is, it might drive the cancer a certain way, and maybe it's more amenable to certain types of chemotherapy. Like, perfect example is BRCA1 and 2 mutation carriers and PARP inhibitors. So, there's, I think an emerging understanding that you don't need to be a specialist to screen and take care of patients, but there's still a very big lag, and there's a lot of providers that just don't want to do that type of testing out there. They think that it needs to be done by a genetics professional like me, or hereditary cancer genetic counselor. But really, at the end of the day, we just got to find the people that have the mutations, and then they can be counseled by people like me or genetic counselors, or specialists in your area. But if we never screen and find those people, we're stuck. The other side of the shop has been adapted a little bit quicker, which is, how do I take care of a patient with cancer? And that's, taking the tumor, grinding it up, seeing if there's, mutations that are treatable with new chemotherapy agents, targeted mutations, precision therapy, things like that, like the new blood tests I'm talking about, where you can screen cancer, longitudinally in somebody to see if it comes back and the circulating tumor DNA is back. Those kind of things have actually uptaken a little bit quicker because there's an immediate utility. You're an oncologist, for instance, you're taking care of a patient with cancer. You can probably take care of that patient a bit better if you use some of these other tools. It's a little bit more straightforward than, this person doesn't have cancer And I don't even like saying the C word to, certain patients if I'm some providers. And I, just feel very uncomfortable even screening them for hereditary cancer risk and things. So I think there's those two camps, and it's just going to take time and education. But I can tell you, medical school now, and a lot of the training programs are just becoming more embedded into the curriculum for sure.
Yeah, which is a good thing. And what's nice about what you've been talking about in the podcast is we talk a little bit about all the tools, right? And adding another tool to your tool belt. Fantastic. And it'd be hard for me to do this podcast without mentioning another tool, which I think a lot of doctors are now having to use, which is AI, right?
Mm-hmm.
We see a lot of patients that are Googling all of this information. Now they're going on AI, getting this information. And that's why we set up DocPod, actually, because we want to talk to real, trusted, board certified doctors like yourself, because I think that still, whatever AIs are going to be built and they're going to help us for sure, a lot of that information is coming from the best doctors in the world like yourself. So this is really important. So where do you think that AI is already in terms of delivering, let's call them real world wins in diagnostics? Are we seeing them already?
Mm-hmm. Yeah, absolutely. Yeah. It's been interesting. I mean, even myself, I now use AI absolutely daily. A year ago, maybe I was using it, once or twice a week, maybe 3 days a week. Now I'm using it probably every other hour. I mean, it's really just been incredible to see, how it's working its way into our culture. And there's no difference in medicine. It's been the same. So, I would say the two areas that have really, taken on AI very quickly, and it's being used today, are imaging. So radiologists, the AI is incredible. I mean, it can really help you, locate things, do, quick notes. I mean, it's really just enabling a much quicker and thorough evaluation of imaging scans. So that's taken off really rapidly. Also pathology. So, when you have tumor blocks, looking at them under a microscope is almost becoming obsolete. A lot of times now the blocks are being, the tumor block itself gets sectioned. Those sections get digitally scanned. And so you don't even have like physical slides, sometimes you just have digital images. Pathologists could, read off their iPad, or laptop, and you're not looking under a microscope. You're just like literally just like you or I would do on our, phones. You just, take two fingers and blow it up. If you want to see a little bit deeper and higher magnification of a certain area, it'll, the AI software programs will immediately point out areas that, look like cancer, for instance. They'll, highlight it. They'll tell you like prostate cancer, perfect example, take a guess on like a Gleason score, 3+3. I've even seen programs that, and we have a Path AI relationship, I should say, at Quest. So we've definitely done a lot of this, even in our own lab. But you can even, even before the pathologist opens up their computer in the morning, it'll already organize which patients look like they have cancer. So that way you can prioritize those patients, sign out the scan, and get that patient moving really quickly towards treatment. I mean, just really incredible. I think when it kind of bleeds over into the molecular realm is when, you can look at, for instance, pathology, and you can see certain signs that look like tumor signatures, like they're already going to be susceptible to maybe these immuno-oncology type agents that you could treat someone with. And you don't even have to do molecular testing then sometimes in certain cases. So I think there's going to be more of a blending of all the worlds. And, again, it's just more information. And as you pointed out, we're always just as a whole society, but, medicine is no different. We're always trying to get smarter. We're always trying to go deeper. Information's power. We're trying to take the best care of patients.
Yeah. And again, it's another tool, as you said earlier, which is great, to be used, AI to be used with, a phenomenal physician with all this data really, really helps. And so I'm curious though, I mean, what about people who don't have cancer? We touched on it earlier, right? And how, they want to be proactive. I'm a proactive person. I don't have cancer. Will MRD testing ever be a part of that routine checkup or cancer screening? Is that where we're going with this?
So once you've had cancer, yes, I think it's going to become pretty commonplace. If you haven't had cancer, yes, I think we're headed towards a world where we're going to have probably an annual blood test, probably after the age of 45 or 50. We'll see how guidelines emerge there. I mean, colon cancer screening now, because, we're not the best as a country of going and getting our colonoscopy for various reasons. I used to sit on the NCCN board for colorectal cancer screening, full disclosure. Because not all Americans, and again, I'm just focused on, Americans here, but, there's obviously, plenty of other countries, but we all have trouble getting our colonoscopies no matter what country you're in. Because it's, challenging to get those colonoscopies. Other things have come up, whether it's stool-based testing, for instance, for colon cancer. A lot of people are getting those type of tests now, but blood-based cancer testing too is emerging. You can see certain signatures, for instance, in the colon cancer, in colon cancers that are consistent that you could look for in the blood. So we're already starting to see colon cancer screening start taking off now in the blood world. There's already some commercial tests that are out there that have insurance coverage, for instance. So I think that you're going to start seeing that a little bit more commonplace. I wouldn't say it's a substitute for colonoscopy, because the benefit of colonoscopy is always that if something's seen, like a polyp, you could immediately address it. You can, so it's really unique in a screen in that sense, because it's a screen, but you could also be preventative at the same time, and you could remove a polyp that could have potentially then developed into cancer. So, I think colonoscopy is always going to be that gold standard, for instance, for colon cancer screening. But having a blood-based test is very exciting for the folks that don't, end up getting their colonoscopy. And then if you think where this whole world's going, well, right now it's looking for colon cancer, and we already talked about the Grail test that looks for a bunch of different types of cancers. And that's where all this is going. I mean, it's going to be this like more universal type cancer screen with multiple cancer signatures in these blood tests.
Which is incredible, because then, like you say, with fewer tests, we might even be able to determine more issues, right? Essentially, which is incredible. And, I think the biggest issue I had when I had my prostate cancer was I was being very proactive, because I do think you have to be an advocate for yourself, right? Mm-hmm. And a lot of my friends my own age, I'm in my early 50s, and at that time I was in my early 40s, they weren't doing it. And even I have friends today, Dr. Slavin, who are in their early 50s, and they haven't gone to get a colonoscopy to do what they're supposed to do. And, I don't know what that stigma is or what it looks like, but we do know that there are people that get scared or get nervous about testing, about these types of things. So some people might hear, genetic test and think of a scary result or high costs. What would you say to them to reassure them?
Yeah. I think it's just, we want to, as physicians, we want to take the best care of people. And, there are things that are scary. And, even me, once a year I get a PSA, and I dread opening the email from Quest, which is where I got it done. And I'm, not my 50s yet or 60s, but, that day will come. And, so I empathize. I mean, both as a physician and a patient in that sense. So, but, we want to catch cancer with as few cells as possible. Period. That's a general statement. Tends to push medicine and drive medicine to having better treatments, diagnosing things earlier, finding things smaller. And patients generally have better outcomes if it's not spread all over your body. That was really my life as a clinician, taking care of patients with high risk variants that put them at, huge risk for cancers, and then setting up their screening and management to make sure that we could keep them cancer free. So I'm always an advocate that information is power. So, I know it's scary, but there's a huge benefit, and it's the same reason that, people don't like getting their colonoscopies. People don't like getting their, pap smears sometimes and different things, but we got to do it, because there's good evidence that says if you can catch things earlier, if you can remove that polyp, if you can catch that cervical cancer early, you can make, major reductions in cancer. I mean, cervical cancer is a perfect example. I mean, that was one of the biggest killers in the world, would kill frequently women in their 20s and 30s, just horrible. And, we came out with pap smears. Look, I'm not saying people don't pass away, unfortunately, of cervical cancer, but, we've made, we've absolutely flipped the table on, the deaths from cervical cancers these days.
Yeah, 100%. And again, I've told all of my male guy friends as well, hey, listen, you can bury your head in the sand, but honestly, if you can just get on the other side of being disciplined and courageous and get that test done, you could have preservation of life. And that really should be the end goal here, right?
Yeah. If we live long enough, we're all going to probably have, some heart condition or cancer or something that's going to plague us. So, let's find it early. I mean, I'm all for finding something sooner, and being proactive and taking care of it.
Yeah, agree 100%. Dr. Thomas Slavin, thank you for sharing your expertise today. Honestly, your perspective, your time with us, the work that you're doing is making a difference. And we heard more about it today. And we really appreciate your dedication for advancing healthcare. It has to be said. Hopefully it is being said. So thank you for joining Dr.
Yeah, thank you, JJ.
Yeah, great conversation. Thank you. Now, before we go, I'd like to leave our audience with the key takeaway from today's discussion, because this is so important. Great conversations spark great ideas, but the right idea changes lives. And this is what we call the clear signal. Again, MRD, minimal residual disease testing, isn't futuristic. It's happening now, and it's helping clinicians track cancer with unmatched sensitivity. Again, what Dr. Thomas Slavin and Quest Diagnostics are doing is innovative. They're turning routine blood draws into molecular insights so that they guide real-time treatment decisions. Again, precision medicine isn't just about the test. It's about access, education, and changing how we monitor disease. It means doctors can now use a simple blood test, which is incredible, to detect and track cancer earlier and more accurately. And Dr. Slavin's team is making that advanced care available to more people. So a special thank you again to Dr. Thomas Slavin of Quest Diagnostics, and those watching and listening, thank you for joining us on DocStars. And as always, please like and subscribe, because again, this allows us to continue talking to these amazing doctors and healthcare leaders from around the world, and continue watching, of course, the DocPod channel, because health, it's everything.
Celebrating the world's best. This is DocPod's DocStars.